We are starting. We are going to do little changes from the program. So we are going to start with Dr. Ramon Rovira from Barcelona. He is a member of the SGC GONCO. So it's a pleasure to present Ramon. He's going to give a lesson about sentinel lymph node in endometrial cancer, indication and guidelines. Thank you, Ramon.
Good afternoon. I would like to thank Professor Saridogan, Professor Mere, and obviously Dr. Bisari for being here with you today, your kind invitation, and all the panelists. I think we are going to talk to a very hot subject, talking about endometrial cancers. And I will starting talking about the sentinel lymph node in endometrial cancer and the indications and guidelines. Sorry, we check the presentation, but doesn't. Sorry for that. It doesn't.
Ramon, you may want to stop sharing and restart again.
I think so. Sorry for that. I apologize, but I don't know what is wrong. Perhaps, Viviana, perhaps we can go with the...
Okay, we can move on with
but I don't know why it doesn't work.
With the second presentation from Matthias Guyu. He's an anatomopathologist from Barcelona, and he's going to give us a lecture about pathological processing of sentinel lymph node and the importance of micrometastasis and ITC. So, Rona, if you can move on, thank you.
So thank you very much for the invitation to participate in this very interesting webinar on sentinel node biopsy in endometrial cancer. And my role is discuss the pathological processing and the importance of micrometastasis and isolated tumor cells. Here you have my disclosures, and this is the outline of my talk. And we will start with a brief background on sentinel node. Of course, sentinel node mapping is probably much better than biopsy, because it's really not a biopsy. Provides staging information, reduces intraoperative risk in opposition to lymphadenectomy, identifies unexpected node draining patterns. From the pathology side, requires extensive pathological analysis of the nodes and identifies low-volume metastases. And I think there is now plenty of evidences demonstrating that sentinel node mapping is a good alternative to lymphadenectomy. It's not inferior to it and provides less morbidity. Which is the significance of micrometastasis and isolated tumor cells? And of course, when sentinel node mapping is performed, we have different levels of tumor involvement. Of course, macrometastasis, sometimes with extracapsular extension. And then we have low volume metastasis, micrometastasis, and isolated tumor cells. And there are many papers in the literature that shows that the largest the tumor volume is in the lymph node, the higher the possibilities of recurrence. So this is really clear. This paper from Ignatov in 2019 raised the question that really patients with micrometastasis had this lower disease-free survivals in comparison with node-negative patients. Of course, the volume of tumor metastasis is predictive of what is in the non-sentinel nodes. When sentinel node mapping is performed at the same time that lymphadenectomy is performed, it's clear that, in some patients, the presence of isolated tumor cells in the lymph, in the sentinel node, is usually not associated with any involvement in the non-sentinel nodes, although there are some cases in which this is happening, and at a higher extent with micrometastasis and macrometastasis. So this is a recent paper from Giuseppe Cucinella. The paper is from the people from Mayo Clinic, but it is a multicentric approach, and they show that sentinel lymph node ITCs have a worse recurrence-free survival and non-vaginal recurrence-free survival compared with node-negative results, but also say that ITCs did not influence overall survival. So these are the two sides of the same medal. And this is a very nice paper from Koji Matsuo using the National Cancer Database Uterine Cancer from the States, showing that patients with ATCs have similar overall survival than patients that are node negative, but interestingly, patients that have ITCs benefit from adjuvant therapy, while the group of Memorial shows just make the rational just in the other way, saying that ITCs in sentinel node does not warrant increased utilization and toxicity of adjuvant therapy. So the controversy is there, and of course you have more information than me to have your own opinion on this. But my field is pathology, so really what I can contribute is with understanding which is the best way to process our sentinel nodes. And of course, I will start with the ESGO-ESTRO-ESP guidelines from 2021. You probably know that these guidelines are going to be updated soon, probably before the end of this year. We will have a paper published on the new guidelines, but in both the one in 2021 and the one of 2024, 2025, I exactly don't know when these are going to be published, demonstrate or emphasizes the importance of pathological ultrastaging in sentinel node. And the problem, and this is pathologists' responsibility, is that we pathologists do not have a consensus on the protocol for ultrastaging. There are different protocols analyzing different levels, 2, 4 levels, and the results seem to be quite similar. These are the two most frequently used methods, the one of MD Anderson, the one of Memorial. They are a little bit different. And the group of MD Anderson demonstrate that or published saying that additional levels were not really changing that much. So they have this approach, which is more modest than the one approach that is used in Memorial. Of course, on the other side, we have one-step nucleic acid amplification, OSNA, which has been also used in the breast. And this is just a paper from Raffone summarizing some of the papers in which a series of patients have been published. So the results are quite good. The sensitivity, specificity, positive and negative ratio are good for OSNA. And the author says that OSNA appears as a highly accurate tool for intraoperative assessment of sentinel node in endometrial cancer. There are many other papers. This is a prospective study from the group of Gemelli, demonstrating that, in fact, OSNA is doing very, very well. Of course, there are advantages and limitations, and I'm going to touch them in a few minutes. So, for example, one of the most important limitations of OSNA is that we are ignoring morphological features. And this is important. This is important, for example, for missing extracapsular nodal extension. Extracapsular nodal extension is associated with bad prognosis. It is infrequent. But if we don't analyze the lymph node at the microscope, we are going to miss that. So I think this is important. Of course, this is the most criticized aspect of OSNA, missing benign inclusions, because they are there. Of course, they are not neoplastic, but they are interpreted as tumor cells by OSNA, and they are usually interpreted as isolated tumor cells, but sometimes they are quite big, but they are very infrequent, less than 2% of the cases, or around 2% of the cases. Of course, there is the issue of tumor heterogeneity. The tumors progress during metastasis. So in the lymph node, you can have differences in comparison to the primary tumor. And if you are not analyzing the tumor at the microscope, the metastasis at the microscope, you are going to miss these changes. And then you are going to miss the incidental lesions, lymphomas, sarcoidosis. Or, for example, this funny lesion, which I like a lot, which is lymphangioliomyomatosis, that can be found in pelvic nodes, like this beautiful case. Sometimes it's very infrequent, but sometimes they are the sentinel lesion for tuberous sclerosis. Another important point is how much of the node we analyze with ultrastaging or with OSNA, and that goes in favor to OSNA. Because if you pay attention to the different protocols that we have for ultrastaging, even the more extensive, you are just analyzing 2% of the node. Of course, in OSNA, you are analyzing 100% of the node. So this is really important. And this is a problem for the papers that I showed to you before, which discuss the role of isolated tumor cells. When by ultrastaging, you are just analyzing 2% of the node, it is clear that some of the nodes that are negative in these papers may, in fact, have isolated tumor cells. So we are comparing the group of patients with isolated tumor cells with a mixture of patients that have negative nodes, but some isolated tumor cells that were missed because in ultrastaging, we are just analyzing 2% of the nodes. So this is something important to take into account. The OSNA requires cytokeratin positivity. And that may be a problem because cytokeratin expression is not 100% representative of tumor cells, and even more, there are tumors that express more or less cytokeratin. So this is, again, a limitation of OSNA. For both procedures, there is a common limitation. And the limitation is that in both cases, in ultrastaging or in OSNA, we are using the criteria that was established for breast cancer. We do not have strong scientific evidence on this scoring for endometrial cancer. So this is also quite interesting. So these are the limitations and the advantages. You may be interested in knowing which is my personal opinion. And I will tell you that in an easy way. Over the last 9 years, I have been chairing 2 pathology departments, one in a big hospital in Barcelona, one in a hospital in Lleida in the region of Barcelona. In one of them, I have been using ultrastaging, and I am happy. In the other one, I am using OSNA, and I am also happy. So this is one case, that was analyzed in the hospital of Barcelona. We are using the memorial criteria, ultrastaging, and it works beautifully. This is one case in Lleida, in we are analyzing OSNA. But let me tell you something. To minimize some of the limitation of OSNA, we have modified a little bit the protocol. So whenever we have a lymph node for Sentinel node analysis, we section the node and we perform touch imprints. So cytological pictures of the cut of the nodes, the 2 halves. If there are cells there, if there are tumor cells there, then the node is sent for conventional ultrastaining because we do not want to miss extracapsular extension. But if the node is negative, then we send the node for OSNA because we want to know exactly the volume of tumor cells that are there. So this is something that maybe can be interesting for some of you. So my conclusions. Ultrastaging and OSNA are good alternatives for analysis of sentinel nodes in endometrial cancer. Each of them has limitations and advantages, and it's up to you to decide which is the best. Regarding ITCs, probably we need more scientific evidence, and probably this scientific evidence is going to be provided by OSNA studies rather than for cases analyzed by ultrastaining because of the limitation of the amount of node that is analyzed. So with that, I conclude my talk. It has been a pleasure, and I'm going to be really happy to take any questions from you. Thank you very much.
Thank you. So a big thank to Xavier Matias Guyu. It was really, really inspiring presentation. I don't know whether is there any question or comment. I don't see any at the moment. Liliana, let me allow me just one comment, personal comment, of the importance of defining low volume metastasis in uterine cancer, endometrial cancer in particular, by performing the ultrastaging. This means that when we want to analyze survival from low volume metastasis, it's important that this comes from sentinel node submitted to ultrastaging. In other words, we cannot compare low volume metastasis with non-low volume metastasis with negative nodes if we analyze a specimen of a lymphadenectomy, because if we find an incidental micro or metastasis or ITC from a specimen from lymphadenectomy, this means that this could be the tip of the iceberg, meaning there is much bigger metastasis in that nodes. And this is not a low volume metastasis, but probably is a larger volume metastasis. Just a small comment.
Yes, you are. I completely agree. Just one thing I want to say to all the audience that in general we are going to do the question at the end, and you can write the question and answer in the using the at the bottom of the screen. There is where you can write any questions. We are really to be on time because we do not have too much time to make question at the end of each. So I just ask to move on with Ramon. If you have the presentation running, thank you. Thank you, Ramon.
Thank you very much.
Thank you. So Ramon will present sentinel lymph node indications and guidelines.
Okay, thank you again. Yeah, I see it works finally. This is my outline. I will talk about general considerations, the importance of low volume metastasis, as Dr. Vidari just commented, the indications in different situations, and finally to take into account the molecular markers with sentinel lymph nodes. For the sentinel lymph node detection, we have to take into account general considerations. Sorry for that, but I don't know if my internet connections has something wrong. Okay. Sorry for that. I have checked it several times, but I don't know why. So perhaps
maybe you can try to use this not in a...
Yeah. I don't know.
Ramon, sorry to interrupt. You may try to switch off your video. It may
Sorry?
increase. If you try to switch off the video, it may increase the speed.
No, but
Turn your
I don't have
camera
any
off,
video.
Ramon. Yes.
Sorry, I don't have any video.
No,
Your
turn
camera.
your camera off.
Your camera.
Okay. Wait.
Ramon, the other thing that I would suggest, if you go back to the previous screen, don't actually go to the slideshow, just run it while you can see all your slides. Yes, so just use the screen to try to run your slides. Yes.
Okay. Can you see it now? Sorry for that.
Yes, we can.
Okay.
Yes,
Okay.
better.
So
So
don't
let's
change the
move.
slideshow, just stay as on
I
the
know. Sorry for that. So, as we are going to explain in this webinar, sentinel lymph node technique is not a simple technique. So you have to take into account surgical technical issues. Obviously, you have to have a very good pathologist team, as Professor Matthias Guiu explained, and to take into account the technical points about detecting the importance of the low volume metastasis, the micrometastasis, and the isolated tumor cells. On the other hand, this technique is safer than the classical lymphadenectomy. We can see by this meta-analysis that it has low risk of lymphedema and very low risk of any post-op and severe post-op complications. Why it is so important, the low volume metastasis? We have the data of this very classical study that we have to know that the incidence of lymph node metastasis is related to the some pathological aspects, and obviously the risk increases as soon as the grade is higher and the myometrial invasion is higher. But as we can see in the last figure classification in 2023, the micrometastases are classified differently than the macrometastases in the pelvic and in the paraortic, because it has a different prognosis. We have to know that the prevalence of low volume metastasis in early stage varies from 2 till 10. That we know that the low risk endometrial cancer, the classical low grade 1I, has a very low incidence of low volume metastasis, even below 1.0. And in the high risk, the prevalence rates ranging from 7 till 15%. And we have to take into account that in the non-invasive serous carcinoma, the very superficial can have up to 10% of this kind of micro metastasis or ICT. When we are talking about different indications, different situations, the first one would be the atypical hyperplasia. There are a lot of centers that are considering more and more to perform sentinel lymph node in this diagnosis. The reason why is that we can see by this meta-analysis that there is a 44% of endometrial cancer in the firstly diagnosed atypical hyperplasia. But on the other hand, the rate of positive lymph node in this sentinel lymph node detection was below 2%. We have to consider that 15% of these final endometrial cancer were treated with adjuvant treatment due to this sentinel lymph node detection. What about the low and intermediate risk? Another meta-analysis with talking about 2,600 patients had a very good overall detection rate of over 95% with a bilateral sentinel of detection rate over 75%. And the incidence of sentinel lymph node metastasis was around 10%, with a very good negative predictive value in the sentinel lymph node. If we talk about high risk, we have to comment this prospective study, which is called CENTOR, which included 156 patients with a very good detection rate as bilateral and very good sensitive and negative predictive value. Two meta-analyses talking about high-risk endometrial cancer. This one included more than 700 patients with, again, very good overall detection and bilateral detection with, again, negative predictive value very high. And the second one included 9 studies, which a bit more than 400 patients with similar results. How can we reduce the false negative rate when we are performing this technique? This meta-analysis talk about which were the factors that differentiate in false negative rate. This study showed that there was no difference in between low risk and high risk endometrial cancer. There was no difference if frozen section was done intraoperative, but on the other hand, the risk was reduced when the cervical injection was performed compared with the other sites, when the indocyanine green was used compared with technetium and blue dye, and when postoperative ultrastaging was performed, as we are commenting during these different slides. And what about molecular markers? This very it's called Seneca study. It's from this year, was published this year. It was wanted to evaluate the sentinel lymph node involvement related to molecular marker subtypes and also the ESGO risk classification. This is a retrospective study that had the collaboration of 16 countries, more than 60 centers, more than 2,000 patients. They detected almost 10% of Sentinel lymph node positive, with an incredible high percentage of low volume metastasis, almost 70%. And we see that the p53 abnormal and the mismatch repair deficient group which have the highest rates of risk of affecting sentinel nodes. And obviously, as high as the ESGO risk group was, the higher positive percentage of sentinel lymph nodes. So, as we know that the ESGO protocol, the ESGO guidelines is going to be updated in the next months. Probably they are going to be presented in Rome in next ESGO Congress in 2025. It is said that sentinel lymph node is indicated in all cases, even in the high risk. And considering that in these special cases we have to perform a site lymphadenectomy in cases of there is no detection of sentinel lymph node, an intraoperative frozen section of the sentinel node is not encouraged, as it would not change surgical plan and may have a poor sensitivity. So to conclude, sentinel lymph node biopsy is a safer procedure than pelvic lymph node lymphadenectomy. The importance of low volume metastases that we couldn't detect them if we wouldn't have performed this ultrastaging. Sentinel in low risk, intermediate risk, and high risk, yes, but be aware of the technique. So we have to be very, very precise in the technique with all the details. And finally, we have to consider as well the molecular markers when we are studying sentinel lymph node. Thank you very much, and sorry for the technical problems.
Thank you, Ramon, for your exhaustive presentation. We are also perfectly on time. So I'm going to move to present the next speaker, that is Nasir Habib from Paris. He's also an SGS Onco member, with whom we work a lot in this SIGONCO. And he's going to present a relation on the rationale for sentinel lymph node mapping, and in particular on the practical implication. So thank you, Nasir.
Thank you, Lily, for this kind introduction, and I'm so happy to be with you tonight to share with you this presentation. Thank you for the organization and for all SIGONCO members and for the organization of SGA. I want to share this presentation. There is some information that has been said by Ramon, and but the repetition is important to fix the idea. So my task is to speak about the rationale of sentinel lymph node mapping and the practical implication. What tracer do we have to use? What is the dosage, and where to inject? So why do the sentinel lymph node came to our practice? It's because in endometrial cancer, the lymph node identification is just to define a prognostic factor to tailor the adjuvant therapy. And you have to know that endometrial cancer patients are a high-risk patient in terms of morbidity, because the risk factor of this disease are the mainly obesity, hypertension, dyslipidemia, so the X syndrome, and the high age, so they are prone for complication. So the aim is to decrease the surgical morbidity of the classical lymphadenectomy we used to do. The main morbidity can be intraoperative, like vessel injury, nerve injury, and longer operative time, and the post-operative morbidity, which is mainly the lymphocele and the lymphedema afterward, and infection and thromboembolism. This is an example for an injury of the obturator nerve in...
Nasir.
Yes.
I'm very sorry to interrupt you, but I'm afraid I'm not sure it's only me, but I can see only the first slide. I cannot see the other slides moving.
Well, I'm sorry. Let me check.
Sorry for that.
Nasir, better if you leave the presentation in such matter, so without the full screen.
Mm-hmm.
Use that one because probably is a problem of connection.
Okay, okay.
Yes,
So
like
do you do it like this?
Yes.
Okay. So we will proceed with the example of the injury of an obturator nerve during a lymphadenectomy. It was sutured in this case, but this doesn't guarantee a correct function of the nerve. The lymph node staging, is it important for endometrial cancer? Many studies has been done, and for example, Kitchener and Benedetti in randomized control trial showed that there is no therapeutic value for systematic lymphadenectomy in endometrial cancer, and the main information is to get the information for the indication of adjuvant therapy. You have to know that endometrial cancer, in patient with endometrial cancer, the invasion of lymph nodes is not very frequent, especially in low-risk disease. So it's not very common to have positive lymph node in low-risk disease. For example, Abu Rustum showed that in low-risk disease, the invasion of lymph nodes goes from 3 to 11%. In intermediate risk disease, we have up to 20%, and in high risk disease, we have up to 32%. So we have to decrease the morbidity of the surgery. This is how we came to the strategy of Sentinel lymph node. It's not the only advantage of this technique to just reduce the morbidity of the surgery, but also it allows to detect the atypical localization. As you know, in endometrial cancer, we can have sometimes skip lesion and invasion of lumbar aortic lymph nodes without invasion of pelvic lymph nodes. So the Sentinel lymph nodes can show you the mapping of this atypical localization. It also allows the detection of small metastases, as it has been described previously by the previous speaker, with the technique of ultrastaging. It's applicable in obese patients, and it's a simple technique to do with the cervical injection only. I don't want to pass a lot of time on ultrastaging, but the idea is that with 1 or 2 or 3 lymph nodes, we can have the possibility to make very thin cuts and detect the micrometastasis and even isolated tumor cells without going into the clinical significance of this kind of invasion. The new guidelines from ESGO in the management of apparent early stage endometrial cancer is to do the total hysterectomy with bilateral oophorectomy for low risk endometrial cancer. The indication is the sentinel lymph node, but if there is no detection, we don't have to do lymphadenectomy. For high-risk patient and with a serous carcinoma, we have to perform the infracolic omentectomy and surgical lymph node staging keep on being an indication in this group of high-risk patient to be performed. A study came from Soliman recently and showing that even in a high-risk patient group, the sentinel lymph node mapping is equally effective than lymphadenectomy, and we can perform a sentinel lymph node in intermediate and high-risk group, especially to decrease the morbidity and to have better tailoring of the adjuvant therapy. Again, this new publication from De Vitis showing that since the invasion of the lymph node is very low in early stage endometrial cancer in low grade, which is grade 1, grade 2, first stage endometrial cancer, we don't have to do ultra staging since it's a high cost, and in this group the invasion rate is low, so it's possible to omit the ultra staging in low grade non-invasive endometrial cancer. Which tracer and where to inject? What we used to see in the application of sentinel lymph node is the blue dye, the indocyanine green, and the technetium. And the studies that compared the three tracers showed that the ICG green has a higher possibility to detect with lower risk of complication, especially allergy, with a acceptable cost. So this is what is recommended to use. I will go to this important study showing in endometrial cancer, randomizing the patients into two groups, in the same patient injecting on one side of the cervix at 3 o'clock the ICG, and on the other side the blue. And the randomization was only the side of the injection, and the conclusion was that the successful detection of the sentinel lymph node was 90% for ICG compared to 64% for blue, which was a significant difference, and concluding to the use of ICG green instead of the blue dye to detect the sentinel lymph node in endometrial cancer. Again, in the same direction, Wang demonstrated in his study about using the ICG green in endometrial cancer that the detection rate was significantly higher than the use of the blue, with 93% rate compared to 81%. And the main study published in Lancet, and also concluding to the high detection rate of ICG green, with a significant difference compared to the blue. So the tracer to use is the ICG green whenever there is a sentinel lymph node dissection indicated. This study showed the safety of this tracer, and you can see that the ICG green has lower risk of allergy compared to blue, with 0.05% risk of allergy compared to 2%, and it has been showed recently by Capasso. Where to inject? It has been tried to inject in the cervix, in the myometrium, by hysteroscopy in the tumor, and even using echo-guided injection. But we have seen that the detection rate is completely convincing using an injection in the cervix in two sites, at 3 and at 9 o'clock, superficial, like 5 millimeter in this under the mucosa, and 1 centimeter in the stroma of the cervix. and it allows a penetration of the tracer in the uterine vessels with showing the lower uterine segment, the parametric and corneal drainage. What concentration to use? There is no consensus about the dose to use, but what has been published with a good toleration, low risk of a complication and good detection. 25 milligrams of ICG, so the full dose of the ampoule, diluted in 20 milliliter of sterile water, and we inject 1 cc superficial, 1 cc deep at 3 at 9 o'clock of the cervix. What happens if we do not detect, and what are the risk factors of failure of detection of the Sentinel lymph node? This study on 71 women with endometrial cancer, non-obese, and compared to 38 obese patients, the conclusion was that the body mass index, the high body mass index, was confirmed as an independent risk factor for mapping failure. And what do we have to do in these cases? Again, Obelix study showed that a high age above 65 years and the high body mass index above 30 has been independent risk factor for failure of detection of the Sentinel lymph nodes. This is why it has been published with this study to answer this problem. Whenever we have a failure of detection, especially in obese patients, it's preferable to use 4 millimeters of volume of ICG instead of 2 millimeter, because Dr. Moreau showed in her study that the ICG volume injected in endometrial cancer in obese patients can be related to higher detection, and 4 millimeter in this kind of group showed higher detection rates instead of 2 millimeter. What about the re-injection if we fail to detect the Sentinel lymph node with the first injection? This study showed that the re-injection can show a detection in a subgroup where we do not find the Sentinel lymph node of
I found this on the web for a particularly obese patient. It's
group. Sorry for this interference. So if we do not find the Sentinel lymph node with the first injection, we can do a re-injection of 2 millimeter again. And if you have an obese patient above 65 years old, think of injecting more than 2 millimeters. And what was being studied and showed 4 millimeters shows a higher detection rate. In conclusion, Sentinel lymph nodes give lower morbidity as a technique than lymphadenectomy. Cervical injection has a low false negative rates. It is a good technique with high success of detection, good reliability, and low risk, and it allows to detect the small micrometastasis. Ultrastaging is mandatory, and consider re-injection if no detection. Use 4 millimeter in obese patients. Thank you for your attention.
Thank you, Nathir.
Thank you so much. Yeah, sorry, Lily.
No, let's go. It's your turn.
No, thank you. I just wanted to congratulate Nasir for his comprehensive presentation. Thank you. Really nice. I can see, I know we are already ready for the next speaker, but I can see a very quick question from one participant, and maybe Nasir could reply quickly. He is asking whether laparotomic application of the Sentinel lymph node concept brings the same results as minimal invasive in endometrial cancer. In the meantime, we are preparing the next presentation. Presenter. Nasir.
Nicolo, better if we have time, you are going to.
Okay. I see.
We are really strict in the time, and maybe we can use the chat and write the reply directly in the chat.
Sure. So it's my pleasure now to introduce a great friend, Ignacio Zapardiel, a professor from La Paz University Hospital in Madrid, who will discuss about Sentinel lymph node algorithm and standardization for the Sentinel lymph node dissection. Ignacio, the stage is yours.
Thank you very much, Nico. Can you hear me? Can you see the presentation? Everything is fine?
Yes,
yes.
Perfect.
Thank you very much, Nico, Liliana, and all the SG team for the kind invitation. And we are talking about a little bit about the algorithm and the standardization of the technique. I have no conflict of interest. And the Sentinel node that we have seen before, it's in gynecologic oncology, has been used for ovary, vulvar, cervical, and of course endometrial cancer. But regarding the surgical technique, because the other aspects have been commented before, just to tell you what we do, that is the same as our colleague before, Nasir, has said, that we use this option A, where we inject in 2 points, and 9 and 3, superficial and deep. And with that, of course, when you have a cervical cancer or endometrial, probably is not very common, but you need to remember that you need to make the punction and the injection in the stroma of the cervix. If you put the tracer in the tumor, it won't work. And of course, ICG seems to be the best tracer, Dr. Habib said. But if you see the view of this landing slope by day, and then you compare of the landing slope by night, you may think, okay, now I can see it very well, so let's go to the lights. And I go there, and you know what will happen, that you will crash, of course. Why? Because there is some knowledge behind how the pathways are developed, and of course there is a technique and experience that need to be followed to have a good landing of the plane. So if we just go for the brighting nodes, we will crash. We will take the wrong one, and we will increase the false negative rate. So regarding the knowledge, we need to know that the drainage pathways are mainly 2. One anterior, that is more frequent, up to 90% of cases, 95%, that it goes crossing the obliterated umbilical artery up to the level of the obturator area and to the external iliac vessels. And then we have another less common posterior pathway that goes medially to the ureter and goes to the common iliac vessels or presacral region. This is very important because it's not just to go and look what is writing in the pelvis. So we need to follow the channels. And of course, we need to know the anatomy. We need to open properly the paravesical space without injuring, bleeding, cutting channels, cutting or injuring nerves. So it needs to be a gentle dissection, looking for the references, looking for the umbilical, obliterated umbilical artery, looking to the external vessels, looking to the paravesical space, and really making an intentional, careful dissection instead of just opening, breaking things and looking for, because you see that something is writing. This is to me the most important thing. This is really essential within the technique. So when you do that, you can follow the channels, as you can see in the left side, where you follow the channels slowly, and then it arrives to something that looks like a Sentinel node. And in the right side, in the posterior pathway is the same. You follow the medial aspect of the ureter, and then you can see where the sentinel is. It's really important at the beginning to maintain the integrity of the lymphatic system, because we need to look for the real sentinel node. If we break the channels, then we will find everything green, and then you won't be sure which one was the real first green one. And of course, sometimes we have secondary nodes. Sometimes maybe you have both channels at the same time, so you cannot know where the tumor could have gone. So you need to take both. But first thing is to go to the anterior pathway, in this case left side, and go. And if you don't see anything, then go to the posterior. And sometimes you can of course check both. I like that Nasir said about the re-injection. I think this is something it should be integrated within the technique. If you see that in the first injection, as you see in the left image, we did the first injection. This is the right pelvic side, and you cannot see anything brightening because sometimes the injection is not that easy. Imagine this endometrial cancer patients that they are obese. Sometimes, the fatty tissue around the vulva don't make you see very well. You should re-inject. So that's why you should open the spaces without damaging anything. And this is the same case in the right picture, where you can see after re-injection what happened. It was amazing. I mean, you have this beautiful tanning coming from the lower aspect, and then goes in the cranial area, in the iliac vessels bifurcation. You see the perfectly how the node it's drawing. So this is something that you really need to do. I mean, you need to follow the channels. If you don't see anything or you don't see any channel, you re-inject and you try again. So the technique we used to follow, and I think most of the people is following, is the MSK protocol, where normally you always make the injection, as Nasir said. You make firstly peritoneal evaluation, so intraperitoneal evaluation of the channels to be sure that it's draining. Then you open the retroperitoneal space, the paravesical fossas, and then you check where the channels are running, mainly crossing the obliterated umbilical artery. You look for the sentinel nodes, and then in addition, you remove those nodes and any suspicious node in addition to those ones. Sometimes you have one node that is a sentinel, and you have another one that is enlarged a little bit, and then you think that maybe, or is attached, and maybe instead of one are two together. It's better to take one more instead of one less, because maybe you can leave behind a positive one. And of course, if sentinel lymph node is not detected, let me say after re-injection, because I will re-inject almost always, then lymphadenectomy it's indicated in most of the cases. Maybe in the very low risk or polymutated patient, maybe it's not indicated, but in the rest, you should do the lymphadenectomy, because this is the only way to decrease the false negative rate. So in detail, let me say again that the technique is essential. It's not something that is really you say, this is easy. I open the space, I look for the node, I take it, and that's all. No, because if not, it doesn't work. Technique is essential. You need to do an adequate cervical injection. If you have ICG, is better than any other tracer. Of course, if you have to do a combined techniques like hysterectomy, pelvic lymphadenectomy, or para-aortic, whatever, the sentinel node biopsy should be the first one, because if not, maybe you will break the channels and then it won't work. You have to do a careful dissection of all channels and spaces. Anatomical landmarks identification, it's mandatory. Lateral paravesical space development, looking for the obliterated umbilical artery. This is very important. again, because you look for the crossing with the channels through the obturator and external iliac areas that are the most common one, because the 90% will be the anterior pathway. So you look for it. If you don't see anything, then you go for the posterior pathway. You need to select the sentinel node with a careful removal without the scratching, rupturing, and all these kind of things, and protected extraction. Because imagine that it's positive, you don't want to disseminate the disease. So remember that you have to have an oncological or to keep the oncological safety of the patient. I will show you some examples in a second. Let me see if it's working. Yeah, I think so. Let me see if the computer goes ahead. Maybe I put too many videos in the same in the same slide. Don't know if it's working. Not very well, actually. I'm sorry for that. It's a pity. Yeah. Okay, let me do something very quick. Let me see if it works. I thought it was going to work, but okay. Let me go only with this one. Okay, like this is better. So you see, we look for the umbilical artery. This is the right side of the patient. This is the external iliac vessel. You see here the umbilical, obliterated umbilical artery. You see how the channels are crossing to the lateral aspect, and then one trick to check if this writing thing is a node or not is to push a little bit. If it disappears, it means that it is not a node. If it doesn't disappear, it means that it's the contrary. If it disappears, it is not a node. If it doesn't disappear like this one, it means that it's the proper sentinel node. You see that it crosses straight to this node in the under the external iliac vein. Yeah, it's not working very well. I'm sorry for that. Let me go ahead a little bit. Okay, so we should avoid a little bit this bleeding. So I like to do it normally instead of with the monopolar scissors. I like to use a sealing device because I dissect, cut, and coagulate. I always try to grab in once. So instead of grabbing again and again and again, I try to grab once and use it for the whole dissection. So I avoid, you see the obturator nerve down there. I try to avoid to grab again and again and again. So I try to keep the integrity in once. But the main thing is that we should select the node properly. Let me try to do it with this one in a separate. Okay, let me go up to here. So this is the left area. You see the umbilical artery here. This is the left area. You see the external iliac vessels, and then we are turning the ICG on. And then once we have selected, you see the channels, the main channels crossing the umbilical artery clearly here, okay? And then we follow, and normally this obturator area is where the first node used to be, and then from them you see some channels crossing the external iliac vein to the external vessel. You see that always, this is very common. I mean, this is the most common setting of this. So you need to follow the channels, looking for the obliterated artery, dissect it, and once we know where the node is, that is here, then we grab it, and then we dissect the node. Then we follow, but you see that these others are secondary, okay? It's moving secondarily from this area, because we're seeing this crossing through the obliterated umbilical artery. Let me go a little bit further. We are just cleaning first. I used to take time to localize the node that you see here. The node is all here. Just to show you the technique. So you see that I grab it. Try not to grab it like this one in the middle, but better in one end of the node. Sometimes you have to grab it, but I try not to grab it many times, just to grab once and then mobilize with it. And let me go to the next video very fast. This is another example of the posterior area. You see the external in the right side, external iliac artery. This is I think the ureter is crossing laterally to this aspect. And then you see how we use the, you see it, okay? And then you see how we dissect with the Thunderbit. It's a sealing device. We like that. Let me go a little bit farther just to show you where the node is. This is an area a little bit more complex than the other one, but you see if you go slowly, but the main thing is not dissection of the node. The main thing is to select the proper one from my point of view. We can discuss later. Okay, and the one last minute, just to show you that sometimes also in the para-aortic region, you can also dissect with a sentinel node in that area for in some cases. We don't used to do it very commonly, but you see that it's a good guide to see where the nodes are when you don't want to dissect everything, or at least when you do a para-aortic lymphadenectomy, and then to avoid leaving behind some nodes. It's a good option just to put this ICG and to remove the nodes and to be sure that you are taking the nodes. This is just one example on how to do it in a para-aortic area. Nothing else. Thank you very much for your attention. I want to acknowledge my team at La Paz University Hospital, and this is my email if you want any question after the webinar. Thank you very much.
Thank you, Nacho. Very, very nice. It was really, really educational. Thank you. Liliana?
Thank you, Ignacio, for the exhaustive presentation and the video. And now we pass on with Gabriele Centini. Hi, Gabriele.
Hi, Liliana. Hi, Niccolò. Thanks for the invitation. And I sent my presentation pre-recorded. Considering the few issues we had, I think I'm asking to the central offices if they can play what I sent.
Rona is going to put on
Otherwise, I will do it as temporary, but it's full of video. Okay. So thanks for the support, and we will be later to discuss. My name is Gabriele Centini. I'm working at the University of Siena. And first of all, I want to thank Professor Saridogan and the organizing committee to inviting me to this webinar that it's, I think is touching a very important topic. My lesson will be focused on anatomical landmark in lymphadenectomy, especially from what concern Sentinel lymph node. That is let's say the thread leading this webinar. When we speak about lymphadenectomy, we can divide lymphadenectomy per se, considering gynecological indication in 4 different levels. The ilio-obturator area, level 1, the common iliac, level 2, the aortic or inframesenteric, level 3, or supramesenteric, level 4. From what concern sentinel lymph node, we are going to focus mainly on level 1, where more than 90% of the cases the sentinel lymph node is located. First of all, we have to locate the area of interest when we are performing pelvic lymphadenectomy. We all know that the pelvis can be divided in lateral and central spaces. And those spaces can be identified in the pelvis as a depression of the peritoneum that is tended between the pelvic side wall and the midline organ. The area of interest for us in this kind of procedure is the pararectal fossa. Okay, so pararectal fossa is the area highlighted in green in this slide that is comprehended between the side wall and the bladder medially. Posteriorly, the limit of the paracycle fossa is the parametrium. Lymphatic pathway of the uterus and pelvis can be basically divided in three. Okay, so we have a path passing through the infundibulopelvic ligament that has a drainage of the corpus and the ovary and goes straight away on the para-aortic area and common iliac area, as you can see here highlighted in yellow, the lymph node. We have a pathway number 2 that include also the cervix and is mainly located on the corpus that goes to the external iliac and internal iliac. And then we have a posterior, a deep pathway, that is the pathway number 1 that drain mainly from the cervix and the vagina, that jump the ilioobturator area and goes straight away posteriorly in the common iliac and presacral area. This drainage is important because if in 90+% of the cases, the sentinel lymph node is located, as you can see here in the slide, between the ilioobturator, the iliac and the obturator area. In a very small percentage of cases, that can be around 1–2%, it jumps straight away using pathway number 1 to the para-aortic area. So in case we are not identifying the lymph node in the ilioobturator area, we have also to search for it a little bit dorsally and higher in the pelvis. Here you have an example of Indocyan in green, highlighting the pathway number 2 that goes to the external iliac and interiliac area. You can see here, following the path of the parametrium over a little bit ventrally than the ureter that you can see here, and going and the bifurcation of internal and external iliac area. This is the classic localization of this of a sentinel lymph node and the pathway number 2. So basically, when we enter the retroperitoneum, this is the area where we are going to work. So our lateral side is the pelvic side wall, represented mainly by the Cooper's ligament and the pubis, the obturator muscles that covers the obturator membrane, leaving a small space at the top of the obturator foramen for nerves, artery, and vein. Going a little bit lower, we have the levator muscle with the arcus tendinous of the levator muscle that is tended between the pubis and the ischiatic spine posteriorly. This is basically lower than the area interested by the lymphadenectomy. The area of the paravesical fossa ends posteriorly at the bifurcation of the internal iliac artery when it gives his anterior branches. So we can follow this area all the way down to the bifurcation. That is also another important landmark for this area. If you are going to arrange this anatomy in a scheme, we always know that our first landmark in the pelvis is the round ligament because it's easily recognizable. We can be helped by the mobilization of the uterus by the manipulator, and you can see here the round ligament covered by the broad ligament that it's a double leaf of peritoneum highlighted in pink and yellow here. So as soon as we remove the round ligament, we open the retroperitoneum and we are straight over the paravesical fossa. So locating this area at the beginning is very easy. This is separated by the parametrium from the pararectal fossa. Our first landmark here is the umbilical artery. The umbilical artery, it's easily recognizable and drive us posteriorly to the uterine artery, dividing the paravesical fossa in a lateral and medial part. And for lymphadenectomy, this plays really a pivotal role, because without locating the umbilical artery, we cannot be sure about the area where we are working in. So as we can see here, the opening of the round ligament drive us straight away in a let's say blood-free area. So here we cannot find any vessel as far as we stay lateral to the umbilical artery. You see here on the left side of the screen the umbilical artery. Sometimes it's not that easy, but before starting to go deep in our dissection, is always wise to spend a few minutes to locate our umbilical artery, that we can see here by transparency in the right video. Once we had located this artery, we can move forward all the way down to the obturator area to search for the obturator nerves that most of the time, as you can see here, has a path that it's really parallel to the umbilical artery, and they might be misrecognized. Okay, so the obturator nerve is more lateral, but is most of the time it has a parallel direction to the umbilical artery itself. The umbilical artery plays an important role because it gives us the internal limit of the dissection area here, umbilical artery. Lateral part is the one when we are working in, and if we follow it in medial to the umbilical artery, it drives us straight away to the umbilical artery. Sorry, the umbilical artery drives us straight to the uterine artery and the anterior trunk of the internal iliac. So this is a very important role. Most of the time, it can be seen by transparency on the abdominal wall, as you can see here in the video. So it's important to lose a little bit of time to locate it, because it gives us the let's say the site of incision of the round ligament. It's always useful to incise the round ligament at the level of the umbilical artery in order to have straight access to the artery and not having a sort of tent that it's hiding the structure behind. Doing so, we of course have a facilitated access to the anterior lymph to the bladder, and we also have access to the infundibulopelvic ligament. Infundibulopelvic ligament is another important landmarks, because at that level we always need to perform a wide incision of the peritoneum all the way down up to we can visualize the obturator, the psoas muscle, and the incision must be parallel. As you can see here, is basically parallel to the infundibulopelvic ligament in a sort of T-shaped incision. Once we develop the lateral part of the paravesical fossa, we come back to the pelvic brim, and our next landmark is the external iliac artery. Very big artery, easily recognizable. This gives us a lot of information about the psoas muscle, about location of the nerves, and concerning the approach to the lymph node. Artery are much more resistant than vein, so it's always wise to start the dissection lateral to the external iliac in case we are performing a complete lymphadenectomy, in order to gain space and get better visibility, visualization of the vein. If we're going to see it in real life, this is the situation. The artery most of the time is easily recognizable, as you can see here. And as far as we go deep in the pelvis, we can approach the vein that most of the time is collapsed under the pneumoperitoneum and the traction we are applying, and can be hidden to your site. This lateral approach to the external iliac vessel give us another way to access the obturator fossa and the obturator nerve. Here, as you can see, we have several different nerves to take care of. The first one is the genitofemoral nerve that is laying on the psoas muscle, and it's located lateral to the lymph node area. So once starting the dissection at this level, close to the external iliac artery, is always wise to spend a few seconds to locate the genitofemoral nerve that sometimes can be wrapped by the nodes, and not that easily recognizable. Moving forward, when we are approaching, for example, the obturator area passing lateral to the external iliac, we can have access, and we might need to dissect this area that is the iliolumbar fossa, that is lateral to the and dorsal to the big vessels, and is very close to the ischiatic spine that you can see here. This area is a nerve-bearing area that include the obturator nerve that you can see now in the video, laying on the lumbosacral trunk. The lumbosacral trunk leaves the pelvis just a few centimeters below, as you can see here, receiving some fibers from sacral nerve to give the sciatic nerve. So we have to take care here not to injure this nerve, because otherwise the consequence might be important. Another important landmark, especially approaching the anterior part, is the Cooper's ligament, because the Cooper's ligament is a fixed point. It drives us to the anterior limit of the dissection, and at this level, we have two important structures that might be identified. One is the circumflex artery that goes, let's say, upward, and is the limit of our dissection, because the node that goes ventrally beyond this artery must not be included if we don't want to increase the risk of leg edema. But once we identify the Cooper's ligament, that it's strong, is white, so it's very easily recognizable, here we know that we have another small vein, and not very big, but important in terms of bleeding. You can see here the corona mortis. There is an anastomosis between the external and internal iliac venous circle, so it must be very bleeding. And we can sacrifice it in case is needed. You can see here the corona mortis and the nodes, so we can underneath the corona mortis, we can take the nodes out. Last but not least, we have the obturator nerve, the most injured nerve in lymphadenectomy. So we always have to take care of this identification. Most of the time is really attached to the obturator muscle. So it's important to have it under vision, especially not at this point of the dissection, because when we identify it, we always have it under tension, under vision, but at the time where we are detaching the nodes from the bifurcation of the iliac vessels. This is at this level, as you can see here marked in the arrow, is the area where the obturator nerve is most of the time injured. So please take care of the identification of this nerve. If we move the dissection beyond the obturator area, and this can be useful sometimes to have a very wide opening of the space. Remember that even if we go for lymph node Sentinel lymph node mapping, is always important to have an easy access to the vessel in case of bleeding. So don't leave you very small, narrow dissection, but try to have it wide. Okay, so here you can see the arcus tendinous of the levatorani going to the ischiatic spine, and here is the area where the pudendal nerve is passing under the sacrospinous ligament. Okay, so this is what you can see beyond the obturator area. I'm not telling you that most of the time we don't need to go that wide in dissection, but please don't do very narrow. Do the most you can. Here is the final view of the lymphadenectomy with the external iliac, bifurcation with the internal iliac, obturator nerve at this area, genitofemoral nerve laying on the psoas, ischiatic spine with lumbosacral trunk, iliolumbar fossa. Okay, so this is the overview. Don't forget that sometimes the situation might be difficult and sticky. Here you can see a very bulky node of the right side external artery. And so here we decide, we knew that the situation might be hard because it was an infiltrative endometrial cancer. We decide to mark the ureter with indocyanine green. So indocyanine green can drive the ureter as a friend and as a landmark in our dissection. As I told you before, the cranial part of the paravesical fossa must be dissected in this kind of procedure, and the ureter is our limit. So when we meet the ureter going in a ventrodorsal direction, our dissection is at the limit. We know that we are entering in the parectal fossa. So in a certain sticky situation like this is, it's not that easy to find the ureter, and indocyanine green can help us. Another situation, again, bulky lymph node attached to the internal iliac artery, indocyanine green in the ureter. You can see that as far as our ureter come on the site, on the vision, on the screen, is always easily recognizable, and the distance between all these organs is not that far. And having an extra help is always useful. You see here that the detachment of the node, and actually the ureter is just behind the node. So this is something you have to keep in mind. Remember that sometimes for high-grade, high-stage endometrial cancer, we might need to perform an extrafascial or type A, type B radical hysterectomy. And here you can see how indocyanine green inside the ureter can help us in locating the ureter anteriorly in the so-called Yabuki space. Okay, so here give us an extra confidence in approaching this area that it's very, very tricky. And I thank you for your attention.
Gabriele, thank you so much. This was a wonderful demonstration, also very nice tips and tricks. Very, very also great dissections. So thank you. We are running short of time, so I'm going to move very quickly to Professor Manoulis Kalampokas. Thank you for being here with us. Who will show us videos of sentinel lymph node dissection in endometrial cancer. Please, Manoulis.
Good evening to everyone. First of all, I would like to thank the organizing committee for today's invitation. I'll be as fast as possible as the time is a little bit limited. A quick recap: we know that we have to remove sentinel lymph nodes in which lymph vessels drain the tumor, and then these lymph nodes may harbor metastases. And it's a minimally invasive technique, so better recovery, faster recovery for the patients. and also as well offers many advantages for pathological evaluation of the specimen. What we do in our hospital, in second department of Obs-and-Gynae, University of Athens, in Areteia Hospital, we use the Memorial Sloan Kettering protocol. We inject 4 mL of ICG in 3 and 9 at 9 o'clock, deep in the stroma, and then superficially, with a very good detection, which, as previous speakers noted, the most common areas is the obturator fossum, the external iliac artery, and then it's not really uncommon to see lymph nodes in the presacral and para-aortic area as well. We should never forget we have 2 types of sentinel lymph nodes. Type 1, which is fully dyed and uptakes the ICG, and type 2, where we have the lymphatic that leads to a lymph node. It's close to the uterus, and in the absence of ipsilateral lymph nodes, we have to consider that as sentinel lymph node as well. So first case is a 64 years of age, grade 3 endometrial cancer, grade 1, radiologically staged as 1A, and we have to cut the round ligament at the level of obliterated artery. We have to dissect properly the paravesical and pararectal space, find the uterine artery and vein, keep the ureter under traction, and keep that. We have also that in our mind as well. Then we have to follow the lymphatics, and then we have to remove the lymph nodes. The primary one is the one it's found in the obturator fossum, and we have to keep in our mind that we have the obturator nerve. However, in this case, we have also lymphatics leading to the para-aortic area, removing lymph nodes from the intra-aortocaval area, as you can see here in the video. Also, we have to check the lymph nodes at the well. We have to use the camera at the same time to completely excise it properly, not squeezing the lymph node. Myself, I prefer to use a Babcock. And then also, after removing the pre-aortic lymph node as well, we found as well a lymph node in the presacral area. The second case is a 44 years of age patient, grade 1 endometrial cancer, radiologically staged 1A. A pretty straightforward case. As you can see, we open the broad ligament. Myself, I love a harmonic, open the paravesical and pararectal space, find umbilical artery, dissecting the uterine artery and vein. As you can see here, the vermiculation of the ureter. We have to always keep that in the mind. Then we use the ICG camera, as you can see shortly, and we follow the lymphatics, and then we remove the sentinel lymph nodes. We should always remember that the first one has to be named as sentinel lymph node. This one, even though removed at the beginning, is the secondary lymph node and not the first one. It has to be labeled properly, and that's for proper pathological examination and evaluation of the specimen. Always millimeter by millimeter dissection. We have to keep the field bloodless. If we disrupt the lymphatic vessels, the whole field will become green at the end, and we lose our pathways. So last case, not a pretty straightforward one, a 54 years of age patient with history of bowel cancer, previous midline laparotomy with sigmoid resection and anastomosis, with a Lynch syndrome, with grade 1 endometrial cancer occurred. And then I used Palmer's point in this case. As you can see, multiple adhesions. We have to remove the adhesions first, repair the bowel if there is any trauma, open the broad ligament. Here, a little bit more bleeding because of the previous operation. We follow the lymphatic, we found the ureter. You have to keep that always in our mind. Dissect the IP as the access was not great. As you can see, bleeder here happens. It's not a big one. It's not from the external iliac vein. We have to remain calm. Use suction, traction, counter traction, and always keep the suction. Myself, I love it as a dissection device. The suction. We have to go over the artery. If the plane, it doesn't open nicely because of the adhesion. It's quite sticky, as you can see. Keep the vein always under control. Try to find the lymph node. Use the ICG camera, remove it completely. And then on the left side, as you can see, because of the previous sigmoid resection, the lymph node is from the obturator fossum is attached to the vascular mesometrium on the left side. However, it's found millimeter by millimeter dissection, and then removed completely. And that's our experience from our hospital, Eritrea Hospital, published in papers in ESGO, and also we participated in Seneca study as well. So thank you very much. I hope you enjoyed.
Thank you, Manolis.
Thank you. Thank you. Very nice videos. I'm sorry that the time was really running, but I now thanks all the speaker, and leave the word to Liliana and Professor Ertan Saridogan.
Yes, I think that we have to close, and I want to thank all the panelists and the speaker for the contribution, and I wish a good evening to all the participants. Ertan.
Well, I too would like to thank the speakers and also the moderators, co-moderators, and invite